to get started. So good morning. I'm Dr. Turi Arnis. I'm one of the anesthesiologists here at Ohio State, the third that you will have met. And you'll meet Dr. Hubble next week when he gives you your first of his lectures. Today we're going to talk about injectable anesthetic drugs. But first off, I wanted to mention that probably the best way to get a hold of me would be by email. So if you email me, I tend to respond in a pretty timely fashion. I'm also in the clinic, so if you have other questions and you want to stop by the anesthesia service, you're more than welcome to do that. So Dr. Bednarski and Dr. Lurch asked me to tell you a few things about your exam on Friday. It is in class. It is multiple choice. There will be approximately 3 to 5 multiple choice questions per lecture. And it will only cover Dr. Bednarski's lectures and Dr. Lurch's lectures. So the lecture today and the lecture on Thursday by me will not be on your exam on Friday. Any questions about that? So a couple of things about this particular lecture. First of all, the notes that you have are not going to be exactly what you see. So there are a lot of photos, there's some video in this lecture that did not make it onto your notes. There's no point in having a video that you can't actually watch on a piece of paper. The written portion of those notes should be basically the same, but there are narrative notes that are posted on Carmen. So if you prefer to read it in a narrative format, those are available for you if you want to just access Carmen. The lecture is podcasted, so you'll be able to see all of the video and the photos and everything else that isn't in your notes. So my overall goals for this lecture are for you to obtain a general understanding of the clinical pharmacology of the different drugs that we use in anesthesia for induction. So we talk about injectable anesthetic drugs, but most of the drugs that we use in anesthesia are injectable, right? So what we mean by, in this instance, by injectable drugs is induction drugs. Okay? And we also want you to have a general understanding of the common side effects of these drugs because there's no perfect drug, right? But then the question comes, what are your goals for this lecture? So with a simple raise of hands, how many of you are just here because you need to be here and you need to want to learn what you need to know for the test? Okay, reasonable. How many of you are just hoping to stay awake this morning? How many of you wanted to come today to see if you should even bother coming on Thursday? How many of you know that you love anesthesia and you definitely want to be an anesthesiologist? I'm going to go with, okay. All right. And how many of you just want to learn it, but you don't love it? All right. So anesthesia is a huge part of what people are going to do in regular practice. Most people don't love anesthesia the way we love anesthesia, but it's going to be something that you're going to have to deal with probably every day. And even for specialists, if you decide you want to be a surgeon or an internist, even a cardiologist, you're going to need to know a lot about these drugs and how they're going to affect your patients. So this is a list of the injectable anesthetic drugs that we have available or that you're going to need to know about. There's been a lot of issues in the last couple of months to years about the availability of drugs in the United States and around the world. So not all of these are available in the U.S. Some of these have been available in the U.S. but are not available now for various political and other reasons, but they still could appear on your board exam. So you need to have some understanding about some of these drugs. Propofol. This is going to be the drug that you're probably going to come into contact with the most, hopefully not in the same way as some other people have come into contact with propofol. It is very commonly used in veterinary anesthesia. It is not currently a controlled drug, but because it's been in the news, it probably will become a controlled drug here in the future. So there's been a lot of movement to try to become controlled, and that way people can't abuse it the way that they have in the past. So because in anesthesia we like to show you bottles of drugs, I made sure that we included a lot of those on the slide. But propofol is an alkyl phenol derivative. And it's solubilized in an emulsion of soybean oil, glycerol, and egg lecithin. And that's going to be a really important point to remember because it can then support microbial growth. You need to make sure that you maintain strict asepsis when you're drawing out this drug. You should never put this drug back in the bottle to be used again on another patient. And the contents of the open vial should be discarded in about 6 to 7 hours. So a lot of people have tried other things like putting it in the refrigerator, or they will, they'll keep it on the shelf and they'll say, well, I've never had a problem. Here in the clinic, we use propofol all day long. And so the last vial of propofol that's opened at the end of the day is usually the one that's open in case somebody gets called in on emergency. You're here at 10 o'clock at night, still okay. But the next morning, it's either going to be the one that's used first if it was opened at 2 in the morning, or it's going to be tossed in the trash, or we actually take it back to pharmacy, and pharmacy will use it in those patients prior to euthanasia where the owner's present. Okay? So at that point, if you're going to euthanize the animal, it probably doesn't matter that there might be a little bacteria in there. So this is an example of what can actually happen when you have an open bottle of propofol for a long time. Okay? So this is about 24 hours that vial was open, and Dr. Josh Daniels did these cultures for us with a brand new vial and then a previously opened vial. It's pretty gross. So I wouldn't recommend using propofol long past the expired date, or at least the open time. You need to keep it within that 6 to 7 hours. Most of the time, you're probably not going to have a problem, but if you did develop a problem, then you have a hard time defending that later, because it says right there on the bottle, don't keep it. So some other things you need to know about propofol is that it's extremely lipid soluble. It produces immediate unconsciousness, and the induction and recovery are both rapid and smooth in most patients. The duration is about 5 to 15 minutes, and so once you've given it, you get about 15 maybe minutes if you are going to try to do something really fast. Say you need to close a really small laceration, but pretty quickly. This is a good option. Dogs and cats are typically able to stand 20 to 30 minutes after you give it. So even though they're awake, they're not really ready to get up and move around and go home. But the duration of action is dependent on rapid redistribution, and then it's metabolized both in the liver and in other places in the body. So you can even metabolize it in your lungs. The majority of it will be metabolized in the liver. So we use it clinically as an anesthetic induction agent. Typically, when we talk about anesthetic induction, this is the process where we're trying to get from awake to unconscious, right? So in the grand scheme of making an anesthetic plan, induction drugs come towards the middle. You're going to start off with pre-medication, so sedatives and tranquilizers that you were taught by Dr. Bednarski about. And then you have opioids that Dr. Lurch talked to you about. And you give those usually at the beginning. You wait about 20 minutes, and then you give your induction drug to cause unconsciousness. And then Dr. Hubble is going to talk to you about maintenance, and maintenance is going to be typically inhalants. But you can also use propofol for maintenance. You can give it as a long-term CRI, keep your patients asleep, and over like hours to days even. So I'm going to actually show you a video of a propofol induction. Make sure I turn off the sound. And so this dog's actually been already sedated. It has an IV catheter already placed, and they're administering propofol. So propofol, when it first came out, people said, you need to deliver it, you need to deliver it over like a minute. And then other people said, no, you need to deliver it over like 3 minutes. And then other people said, oh, screw that, I'm just going to give it over 10 seconds, I'm just going to intubate them. And so there really is no like set way that you need to administer propofol. We usually do it slowly. So you can see this dog just sort of hanging out while it's being administered. And oftentimes they will go through a slight little excitement phase where they pick their head up. And Robin's actually restraining this patient, and gradually the head's going to just gently fall, and they're going to be able to intubate. And this is very typical of a propofol induction in dogs. So the next thing they're going to do is she's going to test, and she's going to open up the mouth. pull out the tongue, and then the student is actually going to intubate this dog. So propofol's method of action is that it enhances the effect of GABA. And that's probably the thing you need to remember, GABA, okay? All this other stuff about it increases choroidal conduction, which results in hyperpolarization of postsynaptic neurons. That's not the stuff you need to remember. Remember GABA. It is a potent respiratory depressant. So this is a dog that actually did receive propofol. It is not intubated, and look at the color of its tongue. Pretty purple, blue, pinkish compared with that. So that's intubated and having been given oxygen. So that potent respiratory depression is going to be something that we always worry about, especially if you end up having a patient that you're going to have difficulty getting intubated. Think of an animal that has a mass kind of around its larynx. Probably going to have a hard time getting a tube in that. You're not really sure what you're going to find when you get the mouth open. Propofol can cause apnea or severe hypoventilation, something you should use with caution. It is dose-dependent, this apnea. So the faster that you give it and the more you give, the more chance your patient's going to be apneic. Propofol also has some pretty negative cardiovascular effects. It causes potent vasodilation, so your patients will be hypotensive. We expect that, but because the duration is so short, you're going to have it for a short amount of time, and then usually those effects wear off and your blood pressure will return to normal. The heart rate usually will increase in response to the hypotension. So if blood pressure goes down, heart rate usually goes up, but it might not change at all. And part of that depends on whether or not your patient's been pre-medicated. You should use caution when you're administering this drug to patients that are severely hypovolemic, because if you do cause them to have vasodilation, you're going to make their hypovolemia worse. And it also causes a dose-dependent decrease in myocardial contractility. We expect that. We know it's going to happen. But if you have a patient that severely, has severe cardiac disease, heart failure, this might not be a great choice. Some of the other effects that it can have, propofol can induce pain or discomfort when you inject it. People report a burning sensation when it's actually injected into a vein. It's not associated with tissue damage if it goes outside the vessel. That's a good thing if you don't get your catheter where you thought you had it. It can be used as an appetite stimulant. It's not the reason I would choose it, right? You don't want to say, hey, my dog's not eating, I'm going to give it some propofol. Sometimes I would probably pick something else first. It's pretty amazing if you've ever seen this happen. You give a very small dose, and a lot of times they're not really asleep, they're not really awake, but they're looking for food. Propofol is also associated with Heinz body formation, particularly in cats. So does everybody remember what Heinz bodies are? Yeah, you do? They look something like that. So Heinz bodies are oxidized precipitated hemoglobin. They're indications of oxidative damage, and cats are more susceptible to Heinz body formation just because of the way they metabolize drugs or the way that they have difficulty metabolizing drugs. Cat spleens are also less efficient at removing Heinz bodies from the circulation anyway, and so it's something that you can see. So for a long time it was thought you shouldn't give propofol on successive days to cats. Most people still do that. They will still give propofol today, and then if they have to re-anesthetize the cat tomorrow, they'll give it again tomorrow. Propofol is associated with poor analgesia, so it shouldn't really be something you use all by itself. And propofol can cause myoclonus. And so what myoclonus actually looks like you can see that kind of jerking, the trembling. That's not a seizure. That's actually just muscle that's moving. And that's typical of myoclonus. Not all dogs will do this. Some will. Usually it's greyhounds, but greyhounds are weird about everything. Other drugs can do this too. So dexmedetomidine can actually do this. So As we all know, propofol has an abuse potential, right? People like the way that it makes them feel. It's kind of considered a hypnotic, and so you give yourself propofol and you sort of feel out of it. It's one of the reasons why some people get themselves into trouble with propofol. So does anybody know why Michael Jackson probably died? Yeah, respiratory arrest. So his doctor, using this as a sleep aid, gave it to him and then walked out of the room to make a phone call. So not the best thing for your patients, so never do that. But it got a bad rap, right? So how many people are using propofol, like, to go to sleep at night? Like, probably not many of us, right? But the thing about propofol is that because people heard about propofol and they think that it's the drug that killed Michael Jackson, people are going into their anesthesiologist and they're saying, hey, you're not going to give me that drug that killed Michael Jackson, are you? So, the thing is that propofol is actually a really safe drug in the right hands. The other thing is that there is the first reported case of death from propofol. It was actually murder. Kind of interesting. This is actually written in the Anesthesia and Analgesia Journal, where somebody decided to kill their ex-girlfriend using propofol, but then because they're kind of stupid, they left the bottles like sitting around her with like fingerprints and stuff on them. They said criminals were smart, right? So propofol does have some other reasons why people use it. I wouldn't recommend it. Propofol 28 is a new formulation of propofol. It has a 28-day shelf life. And this is a veterinary product. It contains benzyl alcohol, which allows it to inhibit bacterial growth. The nice thing is that it lasts for 28 days. So you can open this and leave it on your shelf, and it's cost-effective in that respect. It is more expensive than regular propofol because propofol is generic now. But propofol is not. Propofol 28. It is labeled use only in dogs. So what it actually says on the product insert for cats is that it contains benzyl alcohol, which may be toxic to cats. So when Abbott did this, they actually did it with the knowledge that it would be great for dogs, not for cats, and they actually don't label it for use in cats at all. Could you give it to a cat? Well, you probably could. And most of the time, you're not going to have a problem. But if you ended up with a cat that had a toxic reaction to this, it'd be hard to defend because Abbott's actually telling you don't do it. Any questions about propofol? No? All right. So we're going to talk about the dissociatives next. The original dissociative, phencyclidine, also known as, anybody know? PCP. It's the most potent. Ketamine is the one that we use the most commonly in veterinary medicine. It's the least potent. It has some really great effects and some really not great effects, which we're going to talk about. And then thalidomide is also really common in veterinary medicine. It's only available in combination with a benzodiazepine, which is lorazepam. It's called Tilzol. So the important thing to remember about the dissociative anesthetics is that the anesthetic state that's induced by these drugs interrupts the ascending transmission to parts of the brain. So basically, you're separating your higher brain functions from your lower brain functions. The dissociative state is characterized by what's called a cataleptoid state and open eyes. So basically, you just sort of sit there and you stare off into space. And if you ever see cats that have been given ketamine, that's exactly what they look like. They just look like they're staring off into nothing. The dissociative anesthetics, because you get this cataleptoid state where apparently you feel pretty good, but you're staring off into nothing, it has quite an abuse potential. So ketamine, Special K, or phencyclidine, PCP, or angel dust. You ever thought you'd be hearing that this morning? They're all DEA controlled drugs. Schedule 2 for phencyclidine, which nobody uses as like an actual anesthetic drug anymore ever. Ketamine and thalidomide are Schedule 3. So there's whole books written about ketamine and how cool it is. Dreams and Realities, and there's even papers that talk about using ketamine to induce a near-death experience. Not really sure why this is a cool thing. But, there's a lot of people out there that think it's pretty neat. Ketamine's anesthetic actions are separate from analgesic action. So the way that it works as an anesthetic is that it acts as a thalamoneocortical projection system. And so it limits the sensory input that you receive into your brain. But the analgesic action is due to NMDA receptor antagonism. They work very, very different. The duration of the analgesic effect outlasts the anesthetic effect. So you'll still have analgesia even if you don't have anesthesia. So ketamine actually involves a racemic mixture. So you guys remember back to organic chemistry and they talked to you about enantiomers, optical isomers. There's an S and an R. And the S-ketamine is the most potent. It's more rapid for metabolism and recovery. You get less of the bad side effects like salivation. And with ketamine, you can get an emergence reaction that if you're only using the S enantiomer, you're not going to get. But here in veterinary medicine, we never make it easy for you. And so our ketamine is all racemic. So you actually have S and R. And so if we only had S-ketamine, we'd have probably great recoveries every single time. But it's also really, really expensive to do that. So we use a mixture of the two. It just comes like that when we order it. The duration of action is dependent on redistribution to lean body tissues and fat. And the duration of the anesthetic action is shorter than the elimination half-life. So it's metabolized to norketamine, which is an active metabolite in the liver. And then in dogs and horses, you then have to metabolize the norketamine even further, which is then excreted in your urine. In cats, the norketamine is excreted unchanged in the urine. So you're a little bit dependent on liver and kidneys to get rid of ketamine. In high doses, ketamine can be used as a sole anesthetic. We don't usually recommend that for a couple of reasons. In part, you get a very, very rigid patient. There's no muscle relaxation associated with just ketamine. So you're going to have an animal that sits like this. And you can move them from side to side, and they're going to stay just like that. You get increased muscle tone, you get increased tremors, you can get occasional seizures, and extremely rough recoveries. At lower doses, you can combine it with sedatives, tranquilizers, opioids. So more commonly, we would use a combination of ketamine and midazolam for induction. If you've given a drug like xylazine to a horse, where you are going to get muscle relaxation as well as sedation, you can give just ketamine as your induction drug. Remember, you've already got that relaxation on board. So that's okay. Usually you'll have a better recovery in those horses than if you included like a benzodiazepine along with that, but a shorter duration of action. So I have two videos for you. One is an anesthetic induction in a horse. And the thing that I want you to notice about this is that they're actually administering induction drugs right now. This is one of our anesthesia techs with Dr. Lewis, who's a third-year anesthesia resident. And he's administered those drugs already, and that horse is just standing there. And he's going to stand there for a while with that horse just standing there. So you're not going to see a rapid induction the way you would with certain other drugs like propofol. And we gave that propofol slow the last time, and so you saw a very gradual response. But this horse, still standing there, right? So it usually takes about 30 to 90 seconds for these drugs to actually affect your patient. And the horse is going to go through a tiny little bit of excitement phase, and then he's going to slump over to the side. That's going to push his head up in order to encourage him to sit down, which he didn't do very gracefully. And now he's on the floor, and they're actually going to release the rope and roll him onto his side. So he's not that stiff, maybe a little stiff. All right, and this next is a ketamine midazolam induction in a dog. And so this is usually given as a rapid bolus injection. And this is, I don't know if you know Brandon Michaels. He's in the current fourth-year class. This is him. And one of our techs, Dan. So these drugs are in, and that's Brandon's arm reaching right in front of my shot. And this dog is doing the exact same thing, right? It's just kind of sitting there. to get him into a good position in order to intubate him. And he's still going to sit there. So that 30 to 90 seconds, it takes a while. And gradually, he's going to slump down. They're going to try. You can see how stiff and how hard it is to kind of force his mouth open. They're going to give him a couple more minutes, and then they're going to try again. And hopefully not get yourself bit in the process. So this is ketamine in a cat. So when we administer ketamine to cats, this is for castration actually. So this cat got a combination of ketamine, dexmedetomidine, and morphine, I think. And so pretty relaxed, completely anesthetized. You could do a castration with just this combination, never have to give any inhalants. You know, the biggest thing about this is that you got a short duration of action here. You're going to have to do this castration probably in probably about 15 minutes. Nothing here at Ohio State takes 15 minutes, right? Nothing. So you're going to use this combination when you get to the clinic, but you're going to intubate your patient, you're going to put a catheter in. So you guys get the experience of doing that while it takes the surgeons a little bit of time to figure out how to castrate a cat. You do get dose-related unconsciousness and analgesia with ketamine, and you do get that cataleptoid state that we talked about. They will maintain a swallow reflex, but they will have excessive salivation. But just because they maintain that swallow doesn't mean that you shouldn't intubate them, because it doesn't necessarily mean that they're not going to have a potential for regurgitation and aspiration. So it still protects the airway if you can. You can get an increase in cerebral metabolic rate, cerebral blood flow, intracranial pressure, and intraocular pressure. So ketamine is a great choice in some patients, but maybe not a great choice if you have a patient with a brain tumor. Or if you have a patient that has a desmetocele and you do not want that eye to rupture. This wouldn't be something I would pick. People report amnesia with ketamine. Sounds good to me. You can get emergence reaction. So people also report vivid dreams, extracorporeal experiences, that out-of-the-body experience, illusions with fear, excitement, and dysphoria. So these are probably some of the reasons people like to take ketamine as a recreational drug. How do you know that our patients are having vivid dreams or extracorporeal experiences? I have no idea. Ketamine can cause some potent respiratory effects, but usually they're transient and they're usually mild. You get decreased minute ventilation and you get what's called an apneustic breathing pattern. So what does an apneustic breathing pattern mean? Anybody? They hold their breath. Absolutely. So usually what you'll see is you'll see a patient that breathes in maybe a couple of tiny little breaths. They take in one big breath and they usually hold it on inspiration. And so this particular video has a patient, has a horse hooked up to this anesthetic circle, and this is a bellows. And so the horse is going to take a breath in and the bellows is going to go down. And when the horse breathes out, it's going to come back up. So breath in, and they kind of hold it. That's kind of a long inspiration for an anesthetized patient. And then they kind of breathe out a little bit, and then they breathe in again, and then they exhale. That's a very characteristic apneustic breathing pattern. Swallowing and laryngeal reflexes are maintained but depressed, and like I said, you shouldn't rely on this for maintaining a patent airway. The cardiovascular effects of ketamine can be pretty intense. And the biggest thing about it is that it can cause an increase in myocardial oxygen consumption. So there are some patients where you should never, ever give ketamine to them. It causes cardiovascular stimulation via the sympathetic nervous system. Usually you'll get an increased mean arterial pressure, an increased heart rate, and an increased cardiac output. Sounds good, right? So back in the 70s when they did these first initial studies, they actually took ketamine and they sort of like had a dog open chest. They just sort of threw it on the heart to see what would happen. And they actually found all of these things happened. But the bad part is that it causes myocardial depression, which seems counterintuitive, and it kind of manifests mostly when you have a patient in hemodynamic shock. But the most important thing about ketamine is this myocardial oxygen consumption. So can anybody tell me a patient where you definitely wouldn't want to use this drug? Heart failure, yeah. You don't want to make the heart work harder, right? Probably the most common one where it's an absolute no-no is hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy. So how many cats do you think come in with HCM or HOCM to the clinic? A lot. How do you diagnose HCM or HOCM? Echo? Yeah. So does the presence or absence of a murmur tell you that your patient has HCM or HOCM? No. So how many cats do you think get ketamine that don't have a murmur, and how many do we do an echo on that don't have a murmur? Like none, right? And so there's probably a lot of cats that we administer ketamine to that we don't know have some form of HCM or HOCM. And we don't worry about it, but if you have an actual diagnosis of HCM or HOCM, this drug would be contraindicated. Absolutely not. Some of the other effects about ketamine, because of the NMDA antagonism, it can provide some good analgesia, but usually not by itself. So if you're going to need to use ketamine as an analgesic, usually you're using it in combination with other drugs, like lidocaine, or opioids, non-steroidals. All those things together work synergistically. You do not get any muscle relaxation, and the pH of ketamine is 3.5. So it stings when you inject it into a muscle. Cats don't usually like that. It's actually used commonly in wildlife anesthesia. The anesthesia Bible is a book called Lemon Jones, and there's an entire chapter on the dissociatives, and there's a table with every single dose of ketamine pretty much ever given or reported to be given in almost any species you can think of. We use ketamine in wildlife all the time. Tilazol is another option for dissociative anesthetics. It can combine in a 1-to-1 milligram to milligram mixture with diazepam. And so it's the two drugs together. It comes as a powder, and you have to reconstitute it. The duration of action, the way that it works, all of those things are basically the same as ketamine. But the teledimine and the diazepam actually last for different amounts of time. So with cats, diazepam lasts longer than teledimine. So you get a very relaxed patient. The teledimine is worn off and you still have a very relaxed patient. Whereas in dogs, the teledimine lasts longer than the diazepam. So you've lost your muscle relaxation, you start to get a more rigid patient that's still got the anesthetic effect on board. It is metabolized in the liver. So clinically, when do we use tilazol? You can use it as a sole anesthetic. You can administer it IV the same way that you would give ketamine and midazolam. You can administer it IM as well. So this is actually the regimen of choice for having to anesthetize an aggressive dog, usually prior to euthanasia. And so if you have a dog that wants to take your face off, you need to euthanize it because it bit someone's child. This is actually a really good option. It's an IM injection. You give it, you wait 15, 20 minutes. You'd be able to approach that patient, be able to place an IV catheter, and euthanize the dog. It's not a favorite among most of the anesthesiologists, at least in dogs and cats. They tend to have a little bit rougher induction and a little rougher of a recovery than if you gave ketamine and midazolam, even when you give it IV. Tilazol can actually be combined or reconstituted with other drugs other than sterile water. So most commonly, we actually do this in pigs. We give tilazol in combination with xylazine and ketamine, commonly referred to as TKX. And so this is a video of what a pig looks like before it's been given TKX. They're having to snare it, and they're going to inject it into the neck. He's unhappy. I decided not to play the sound part for you. It would wake you up for sure. And then they're going to to give him a good 15-20 minutes. You can thank Caitlin Wiley for this video. I particularly enjoy the butt end of the pig. But you can see he's starting to get a little ataxic. And then he sort of falls, but he catches himself, and eventually he's just going to slump down. Oftentimes, we kind of back off our doses of TKX, and then we give them enough that they become sedate, that they are recumbent, but it's usually not enough for them to do surgery on, and then we usually mask induce them or intubate them and give them inhalant depending on the duration of the procedure. Yeah, he's going to fight it, isn't he? Waiting, waiting, waiting for him to fall down. This is a lot of what pig anesthesia is, waiting for them to fall down. Yay! All right, Tilazol has also been used for wildlife capture. It's less common than using drugs like ketamine, or there's some pretty potent opioids that Dr. Lurch mentioned briefly in his lecture, carfentanil or etorphine. But Tilazol has been used. Unfortunately, Tilazol has gotten kind of a bad rap, especially as it relates to tigers. So this is a tiger that we anesthetized here. It did not get Tilazol because people were all freaked out about Tilazol. It did get ketamine. And so the thing about Tilazol in tigers is that there was a report that came out that basically said Tilazol kills tigers. And so nobody, any responsible person doing tiger capture should never use Tilazol. And then there's a very nice article in the Journal of Wildlife Management that talks about how this one report that talks about 2 tigers that died all of a sudden got generalized into you should never give Tilazol to a tiger ever. And it's a really interesting phenomenon when it comes to many of the things that happen in veterinary medicine, that you can take one story of my dog died after it got propofol, so you should never give propofol to any Tibetan terrier ever, right? The CNS effects of Tilazol are very similar to the effects of ketamine. The teledinine effects predominate later in the anesthetic period in some species, like dogs. So those diazepam will wear off a little bit faster. You still have the teledinine on board. You still get that cataleptoid state. It's very common with ketamine. You do maintain the swallow reflex and the excessive salivation. But Tilazol has not been associated with some of the other things, like the increased cerebral metabolic rate, the increased intracranial pressure, the increased intraocular pressure. But there hasn't been a lot of research done on Tilazol in veterinary medicine. We use it, it's only licensed for use in veterinary medicine, but people sort of took the effects of ketamine and generalized it to Tilazol. Is that a good thing to do, bad thing to do? Well, if ketamine causes those effects, and there's a potential that Tilazol would, I probably would avoid it, because I don't know for sure. I'd pick something else if I thought it was appropriate. The respiratory effects are similar to ketamine, though. Transient, mild respiratory depression. You can get that apnea-stick breathing pattern, the same as with ketamine. You do have those swallow reflexes. Cardiovascular system, increased mean arterial blood pressure, heart rate, and cardiac output. But due to the inclusion of the diazepam, your cardiac output often remains unchanged. Your blood pressure transiently decreases and then increases. Your heart rate often goes up. And Tilazol has not been associated with the increase in cardiovascular or the myocardial oxygen consumption. And so, even though it hasn't been demonstrated, I probably still wouldn't pick this for a dog in heart failure. I still wouldn't pick it for a cat with HCM or HSCM. I'd rather pick something that I know isn't going to cause me a problem later. You do get good muscle relaxation with Tilazol. because of the diazepam as opposed to what you would get if you gave just straight ketamine. Are there any questions about the dissociatives? Yes.
Do you have to worry about the lucid dreaming pattern?
Do you have to worry about it?
Like if it happens to you?
I don't. And the nice thing about an apneic breathing pattern is that they're still breathing, right? So as opposed to propofol where you get apnea, with an apneic breathing pattern, they're still breathing. And so sometimes it can be a little bit annoying. They can have this huge inspiratory time, and so their chest is this big, right? And then they breathe out because their whole body shakes as they breathe out. So sometimes the surgeons find that annoying, but do we really worry about what surgeons find annoying? Well, sometimes we do, right? They still have to be able to do their job. Luckily, this is a transient phenomenon. It's apneic breathing, but it's only going to happen for maybe 15 minutes at the most. And they are still going to be ventilating, so that's a good thing. So maybe if you have a patient with that mass by its larynx, giving ketamine might be a good option because at least they will still be breathing while you figure out if you need to do a tracheostomy. Any other questions about propofol or about the dissociatives? No? All right, you guys are good to go. We're going to finish these atominate barbiturates MS-222, and I'll fax them on Thursday.